Um, okay, so we will get started. Thank you everyone for joining this webinar. We are going to talk about AI and practical uses of AI in health plans. I'm very excited to have Tina Duringer and Mamta Majumdar um, with us today. I met both of them through my healthcare conference journey, and I am so glad I met them. They're amazing human beings and very kind to me. But Mamta and Tina, you are both former providers and practitioners, and you've moved on to like leadership roles across health plans and provider groups. And now instead of taking care of one person, you take care of many people all at the same time. I would love to hear from both of you your own journey, your own story, and what that journey has been from going from like bedside care to health plan leadership and like what your clinical background has, how it has shaped how your perspective of AI and opportunities in AI is at the moment. Tina, perhaps you could go first.
Sure. So I'm Tina Derringer, and I've been in healthcare for almost 20 years. I'm a nurse, still licensed, and actively practicing nursing in consulting role now, though. I started out actually as a cardiac nurse. So 20 years ago, it was really difficult to have just one job in healthcare. We would work two jobs. So I would do that and work urgent care, picking up some night shifts and weekends. And eventually that ended up moving into, I became interested in care management and how do we help these folks that have chronic conditions or that have needs that are outside of just our regular care delivery um, through the years. So that was on the provider side working to build care management, figured out what NCQA accreditation was, and that opened up the whole world of quality to me through that care management lens. Um, Spent a number of years in care management, program development, and had the opportunity to do a joint venture between a health plan and a provider group, uh, which was very interesting to see how that insurance and how the provider side would work together, right? That was one of those earlier models where you could see the opportunity come alive. And that's when I eventually made that switch over to the payer side. Over the years, I've done almost everything on the clinical side. So UM, CM, quality, stars, HEDIS, but keep coming back to quality. Been in consulting for the past 8 years. I've had my own consulting firm, Derringer Advisors, which I'm the CEO and the primary advisor for our firm. And we really focus mostly on that quality side, but we do support UMCM, but everything ends up coming back to that stars piece, right? There's so much moving for stars, HEDIS, all of those quality metrics. And as we see with the proposed final rule, it's always moving. How do you keep up with it? So it becomes that vicious cycle for the plan side. So with that said, I think AI is extremely interesting. So I started my firm, just a year and a half ago. I said, how am I going to do this by myself? And, I went from a small boutique firm, but we had a great amount of staff to now I have to do this solo and bring in some folks, to be able to support on this. So that drove me actually to start looking at AI opportunities. And I think some of those early use cases we started to figure out early, you couldn't use it just generally like people initially thought. You can't put whatever you want in ChatGPT and expect to get an answer for the provider or the payer world, right? We have all of these rules and regulations that don't necessarily line up in this format that AI likes to digest and give us answers for. So that was really my early driver for getting involved with AI. And that's when I started to learn about agents. And then I think the world opened up for me. And I became very curious. And I was on one of your early webinars, need to, and you had the folks, some of the other folks you used to work with, and that have done some great things. And I think there's great opportunity in AI, but I also feel strongly as a clinician and having that background that we also have to keep humans involved and we have to protect that clinical side of what we're doing with humans, right? So that's such an important concept. So it, why why I find this interesting is how do we walk that line and be able to find solutions to, healthcare costs are out of control, quality is difficult to manage and maintain, and yet still make a difference, right? So I think there's an art and a science there.
Yeah, I absolutely love it. I absolutely love that you tried to take care of larger group of people, launch your own firm, and it was all about like productivity driven. How do I do all of this by myself? Which is fascinating. And totally with you in terms of like there is a lot we can do with administrative stuff with AI and agents, and we should be super careful about doing anything clinical with the AI agents, at least not autonomously. Um, but I'll pause there. Dr. Majumdar, how about yourself? Please give us an intro to you and to like what have you encountered in terms of AI as you like went from practicing physician to a health plan leader.
Yeah, Mamata Majmandar, family medicine physician, like Tina, practiced for over almost 2 decades, working in a multi-specialty group. And for me, a lot of it was based on efficiency. I, when I was in practice, I fortunately was really quick. I could see, 25 patients a day and get really good care and get my notes done on time. And we had a dictation system. I don't know if anyone still remembers the little recorders. We had recorders and we had handheld devices. And I was always looking at how you could improve efficiency, whether it was through setting up templates or process improvement and flow. And I really enjoyed seeing patients. And at some point, probably after, whoops, technical difficulty. After about 15 years, I realized I wanted to do more. I've been very focused on prevention and giving people the education, the tools, and resources in order to help them make decisions. And what I learned from my patients is they would come to me and say, I don't get this type of information elsewhere. And it just didn't make sense to me. Um, when people come in for healthcare, they don't know what kind of questions to ask. It's like me trying to determine how to build a program. Um, so I decided to look at other models of care and how I could continue to improve in that spectrum. And I worked in a federally qualified health center because I wanted to see how that type of setting was different. And we did a lot about quality, and I could see a lot about process improvement. It was my first real touch of NCQA and how coding processes were a little different than a general practice that's there. And I still wanted to learn more. And that's where I switched over to the payer side. Worked for Medicaid, really got to see something from a different population that's there. I took care of Medicaid, but not such large populations. Um, and then from there, I went into a commercial health plan. It's just continuous learning and building. In terms of AI, when I look back as a practicing physician, there were so many things that I would not have even been approached or understood if it wasn't outside the healthcare setting, because all I did was see patients every day. My goal was seeing patients. And unless someone brought to me from administration ways to improve efficiency, I wouldn't know about it, whether it's care management solutions, fraud, waste, and abuse, prior authorizations. You're in your silo, I say, when you're working in practice. And so being able to be in other areas of healthcare has been phenomenal to learn about what's out there. Um, I love the fact that AI can really take large processes and simplify it. but there are a lot of, as Tina had mentioned, there's a lot of rules and regulations you have to be wary about. It- Most people, like, there was a tech fellow, and I don't remember his name, but he was talking about we have all encountered AI, not really known about it. And I'm talking about a routine EKG. So I'm talking about from the medical perspective. So the EKG is electrocardiogram. It's just a tracing of your heart. And for years, we've had a machine that we have used, and that machine will see that tracing and tell you what that tracing means. However, you have to review it to see if it makes sense. There's so many times on the EKG it would say this person's having a heart attack. They're not having a heart attack. And so what I see with AI is there will always have to be a human that's there to look at the information that's generated. And when we're building these programs, all it takes is one very easy error to make the output nonsensical. Uh, so that's a little bit of what I'm doing there. I currently do consulting, and I have a great interest in prevention. That was my background, especially with caregiving and fall prevention. Um, and AI has been so phenomenal, I have decided to do vibe coding. So, Neitha, you asked about what we have been doing for AI. I've been able to use AI to help me build an application. And there are a lot of bugs in the application. I say, I want you to correct this. And it says, it does its little computation and it says, I've corrected it. I go back to my app. No, you haven't corrected it. So, there are still flaws in the system that are there, but I think it's giving more people the opportunity to try new things. And if we can do it right, we can actually improve the processes that are bottlenecks in the whole healthcare system.
Yeah, I absolutely love what you said about, just like with Tina, you started with efficiency pieces, then it's actually been with us for a long time, and just the opportunity to do so much more, like democratizing some of the specialties that are locked away. It's like you don't always need an engineer to do simple things until like now, but and you do have to check. You have to check because it's going to continuously get better as you check more. But as of right now, you keep trying, and there's some things it's very good at, and some things it's going to get better at. And if, just the last few years has been any indication, the pace of growth and the pace of advancement and how good it's getting at things is if it's going to continue, that's going to be like pretty amazing. Before I continue and have like list of questions, I'm dying to have this conversation. I want to do a couple of housekeeping things. One, this webinar is being recorded. After it is over, we will post it on our YouTube channel. You're welcome to see it anytime you like. During the conversation, at any time during the conversations, if you have a question, just type it into the chat box. We will answer questions throughout the seminar and throughout the webinar. If we don't get to all the questions, we will answer them in a follow-up email. So looking forward to that. And finally, there is a survey at the end of this webinar, at the end of this conversation. We would really, really appreciate it if you fill out the survey and let us know what is resonating, what is not resonating, and more importantly, if you have other ideas of what you would like to have a conversation with, we will attempt to go find the experts and have a conversation around it. If you have questions around it, send them to us. We'd be happy to try and go find answers. Um, from our side, I am the CEO and co-founder of Lilac Software. We are a technology company focused on healthcare. We are very, very deeply embedded in MA plans and stars in quality. We do everything from data analytics, insights, forecasting to AI agents to close gaps. Um, happy to have you all here. Let's have a few questions and a set of conversations. Dr. Majumdar, my first question is for you. You have been across multiple health plans, across multiple healthcare organizations. I would love to hear if there are any patterns that you're seeing in successful AI strategies, and if there are any differences between like different types of plans. Does it matter if it's a Medicare plan or a commercial plan or Medicaid plan? Do they approach AI the same way? Are you seeing them approach it differently? Yeah, would love to hear your thoughts on that.
So I love this question because whenever I think about the different plans and success, it's really trying to understand why is that plan different? So when you think about a Medicaid plan is serving a much different population than a Medicare Advantage plan. So you're talking about ages and differences that are there. And with the Medicaid plan, you also have different state regulations. So I have seen uh, opportunities where you're utilizing AI on the process of finding information. Let's say a health plan, oftentimes they do approvals. They do approvals for services in place. When they're reviewing approvals based on the state regulations and guidelines that are there. If you have multiple health plans in place that you're monitoring, you can use AI to create information on is this a covered benefit or not? Is this is this information is there a state regulation that this should not be covered? Are there things that we're missing? So, taking that information to help speed up the prior authorization approval process has been very, very successful. And you just need to know your population that's there. When I think about smaller health plans versus larger health plans, a smaller health plan, they're a little more nimble so that they can incorporate AI and do pilots a lot easier than the turnaround time for a larger established health plan that's there. And when I think about it from the clinical space, we're using a lot of it initially is based on AI with I'm gonna I keep holding this in front of my face with dictation, you know, for charting. That's what physicians are using it for. And that's a really low-hanging fruit. And it's an easy thing that helps to improve processes. And then also from the clinician space, if you're a Medicaid or even a Medicare plan, there are things either in your contracts that are required for you to meet as well as federal regulations, you can easily, the plans are utilizing uh, AI in areas where you have a lot of manual processes where you're consuming a lot of information. So, for example, quality, and I'm sure Tina may have more insight on that, but you're using it for quality measures. Being a family medicine physician, my patient may be seeing an endocrinologist at another institution. They may be sending me notes. It's not in a particular click box in my medical chart. And oftentimes, the manual processes, you would have someone review this information so you know, has this person had the appropriate testing, whether it's for hemoglobin A1C. Now we can actually take this information that's in, summarize it, and pull out what you need, and then do data aggregation associated with it. So there's so many opportunities within that space. I could go on even more, even with fraud, waste, and abuse and audits that are there. If anyone has a question, put it now because I'll be happy to answer what a use case might be. But it's really finding what you need done in your health plan or in your organization that is taking a very large overhead where you could simplify that process and either improve your member outcomes, improve throughput, or even increase revenue associated with it. That's what I've been seeing.
That's amazing. Thank you. Thank you. Um, Tina, my next question's for you. You are deeply, deeply embedded in HEDIS and star rating and quality and accreditation. Where do you see AI making the biggest impact? And especially when it comes to like health plan quality, performance, and compliance.
You know, a year ago, I would have given you a totally different answer than I'm going to
I
give
think
you
it would
now.
be really awesome to hear both answers.
A year ago, I would have said, well, there's a long road to get there. Um, but in this last year, multiple health plans that I've worked with are building AI platforms internally. And I think the road looks very different. I would have said a year ago, we have a lot of kinks to work out, and I would have thought maybe plans would have went out and bought more tools or AI platforms. I'm seeing a lot more internal building than what I expected. But a lot of that is because uh, the safety around it of the data and the protections. And, I attribute that to like the Microsoft Copilot model, right? People feel like that they are in a safe space if your AI is in your ecosystem, and you have that in your on premise, on the cloud, whatever, in your data. Um, Now I think that there's going to be significant traction of where we're going to see this in the quality space. I think there's a lot of use cases where we see, I know you've heard me say this, we have a lot of unstructured, disjointed data. The language is not unified when it comes to data for providers and payers. And, the models are, I was just reading a great article about even ACOs and, their models and why isn't quality aligned across the board? It's kind of a hot mess. I think AI has that opportunity, and now we're seeing where models can take unstructured or, data and actually be able to use it. So I think that was one leap forward. And if we can, start thinking creative about how we can make that impact, talking about the dictation, that always is in my mind. We have AI scribes left and right. I get approached probably once a week from that type of company, looking to get more into the market and so on. But nobody's out there. I shouldn't say nobody. Very few are trying to actually solve our problems that we do have with how do we get on the forefront of closing gaps. I know you're doing some of that work, but I do see like in the next couple of years that we're going to have an automated process for that, where we're going to look at HEDIS, we're going to look at stars. We'll have dashboards with real time within a few weeks data. I think claims is going to be our biggest barrier there. But as right now, a lot of the budgets, when we look at quality and stars and HEDIS, providers are supposed to be one closing a lot of these gaps. I mean, that's why a provider is contracted with the payer, but it doesn't happen for various reasons. So that's when the payer, will do at-home test kits or they'll do their interventions from the payer side, but it costs those plans a lot of money to go out and do these interventions. I think that AI will be able to start moving that needle a little, so that we're not sending out things to members that don't necessarily need it. It can trigger, this has a care gap or getting close to the end of the year. This member, looking at predictive analytics, this member typically doesn't close the gap. So this is going to be our proposed intervention. I see a lot of those types of activities bubbling up, but they're coming from internally from plans, not necessarily it would be in conjunction with a vendor or conjunction with a AI solution, but I don't see somebody yet necessarily solving that together, but I see plans thinking in that direction. I do think that now with the new proposed final rule that we're going to have a little bit of shift in some of our priorities. So I think it was Dwight that had a great post the other day on LinkedIn. I didn't get to read the whole, proposed final rule yet, but I was talking to a friend over Thanksgiving and I said, boy, CAPS is going to really, significantly impact this.
Very
And
good.
Dwight posted out there like almost
Yeah.
50%.
Yeah.
So when you think about what AI can do for your member engagement in your call center, and we'll get into this a little more because I have a couple of my responses to our questions based off that. I think it's going to be a game changer, and I am guessing that movement to that direction is going to happen faster now with the changes in the proposed final rule and that CAP's impact. It's huge.
Yeah. that is very insightful, and being able to close gaps at scale across all the measures, across all of the members, at the right time is one of the few things I think computers and AI are actually good at recognizing that and triggering it. But
Right.
appreciate you bringing that up. Actually, I have a follow-up question, the same thing. So, health plans and providers, they often have like different data systems and different priorities. Um, where are you seeing the operational impact on the, let's say, the payer side? And I'll have a similar question for you, Dr. Majumdar, on the provider side.
Well, this has always been like one of my mental challenges is why do we have to have such disjointed processes? But that's for another call, another day.
Yeah.
But I do think that there is going to be, we're going to see a lot of operations around what you were saying, fraud, waste, and abuse.
Yeah.
That's a hot topic. Here in Arizona, we had one of our biggest fraud cases, and should have wrote this down. It's like 30 million. So it was crazy amount of fraud for the one of the skin replacement. I forget what it's called for wounds. It was one of the wound care frauds that took place. These are all like AI can identify when there's billing. We start seeing some of these trends happen, and it can learn from previous trends. And so I think as more and more data is collected and some of these fraud, waste, and abuse type platforms are built and that they could start learning from previous cases, they're going to become really robust. So that's going to impact both the payers and the providers, right? Because sometimes they're both impacted from a fraud case that, you have to look at where it's coming from. But I think there's some applications out there outside of that. So I want to talk about one where we're for quality, we're looking at readmissions a lot.
Yeah.
And so not only in the fraud, waste, and abuse side, but from, quality and that side of where does the provider also contribute and the payer is impacted, right? So both of them. And one of the programs I think that has had a little bit of talk out publicly is Kaiser did this hospital transition program, and they used AI to help identify the members that would be impacted. I think they had almost a 20% reduction in
Wow.
all-cause readmissions from it. And, so you look at that, and I think there's a use case there. And, Kaiser is its own unique little situation being a payer and a provider, but I think there's things that can be taken from that and say, how do we look at this from the other side of it and maybe work with those payers and providers together. The other piece, it's hard because of that data is so disjointed. I think we need to figure out how do we get EMR information. And I know there's organizations out there working. How do we get all of this to line up to be able to be interactive? And I know that this is some of the work that we're looking at for the AI initiatives, that Trump has put forward. We have some new CMS things that are going to be happening over the next couple of years, but it's that data and information barrier and just that sharing that's become makes it so difficult
Yeah.
for information to go back and forth. It's hard to build something that can cross both lines.
Yeah. And there are like pockets of things that are like good and pockets of places. And I'm always like a huge believer in like you start the snowball at the top of the mountain, let it be small, it'll be fine. Just start whatever you can, right? And there we do have some states that have really good HIEs and ADT information and the transition of care piece, right? Like eh, Kaiser, what Kaiser did, they are the epitome of doing things really well. But like what Kaiser did is actually possible in many California areas where it's like you listen to the ADTs, you have an agent that just is listening to all ADTs, and the minute it hears one, it like starts calling the member and starts calling the provider or group to just like hook them up together, right? Like it's like let's go figure out what's happening. And so I think there are definitely pockets of places, even if everything is not awesome, that's okay. think there are small pockets of things that we can like take advantage of and like really bring to bear some of the value here. So really appreciate
I
that.
don't,
Um,
I don't think people realize how fragmented even ADTs, a lot of bigger plans take that for granted. Some of the regional plans, even I am not even going to say small plans, still are challenged with ADTs and their contracts and their relationships and HIEs. That is still such an issue across the board. So I agree with you. Like that's an initial piece that could solve, a whole host of problems. But even those basics, those are some of those core building blocks that plans are still struggling with when, it'd be great to have this AI solution, but if we don't even have ADT feeds, that's a challenge. But, so we still have people that are combing, through Excel spreadsheets of admissions, 2, 3, 4 days late, after
yeah.
or discharges.
Yeah, and I think like people combing through things is by default. Like that is you've already lost 3 days out of 7 in that case. So totally with you. Dr. Majumdar, similar question for you. Like what are you seeing operational or other improvements on the provider side?
Yeah. On the provider side, actually, the use case that you mentioned, there is a provider, it's a smaller facility that I'm aware of, that they were very successful in getting their patients to follow up with them within 3 days after they had a trip to the emergency room or after they were discharged from the hospital. It was taking a significant amount of manpower or staffing to call people to figure out what was going on. And this was extraordinarily successful for them in that scenario. Another place we're seeing a lot of it, and I'm going to mention it on the health plan side, for a variety of lines of business, is using the dashboards that Tina mentioned. Again, it's all about, my background a lot is on prevention. And so a lot of this is early identification, whether it's for a particular disease state, COPD or CHF. You can have information from your remote monitoring devices or other data that you're getting into the health plan in place that's giving you information to predict what's going to particularly happen to a subset of patients. And that has been extraordinarily helpful because you can take that information and do outreach, and you can quickly find out how they want to be outreached, whether it's asynchronously, whether it's a call. So that has been very successful. And it's helpful for the nurses that are doing the case management or the care coordination on these members to know which ones are the members that they need to flag first. You know,
Mhm.
when you come in for the day, which
Yeah.
which ones do you need to do for risk stratification? In terms of providers, other use cases where I'm seeing it, um, the biggest impact really is for dictation and helping with summary of information that's there. It's also helping certain plans that they need to ensure that they're capturing certain codes for high complex codes in place. It's helping pull that data into their notes to help them find that. And it's also helping do the pre planning visit. So they're getting information in place if it's an established patient, what labs have been done, what chronic disease processes are in place. To me, it's so valuable to have that. I I think the biggest thing is whenever you are implementing a new process, that it is so important that you are doing your testing alongside of it. And I know we'll probably talk maybe a little about it later, but Q&A testing to ensure that the information you're receiving is accurate, especially when you're dealing with any sort of disease process or where it may affect a member. That's extraordinarily important that you're 99.99999% accurate with your new process using AI compared to the existing process that's going hand in hand.
Yeah, yeah. And that is extremely important that you didn't say 100%, because I think 100% is going to be a while, but like getting up to 99.99 is already so helpful, right? Like if it's 50% more effective than it was before, I think we just saved a whole lot of people a bunch of pain and angst. So but in terms of like building AI capabilities, like either health plans or provider groups, they face a whole lot of like decisions around like are they going to do, Tina, you mentioned this earlier too, they're starting to build internally. How do you, when you're talking to your clients or when you're talking to your health plan or provider friends, how do you help them think through like um, deciding or recommending how, if it should be a partnership or if it should be doing everything themselves? How do you advise them to assess AI solutions and make a foundational investment or to leverage AI effectively? What do you tell them?
So first thing that we talk about, even before we get to the discussion if they should use a vendor or if they should build internally, is we look at they must have a governance, right? So we are big on having the AI governance, the data governance, all of those pieces, and those folks being at the table and active in this process because it does impact every part of the organization. You need your data, your IT people, you need, your engineers, you need people from the business side, right? So if you're going to do something that's going to impact care management or make sure you have the right people that are part of that governance structure. And then we do have a basic, it's almost like a program description for AI governance that we work with our clients where we lay out almost, this is what we do and this is our policies, this is our procedures, this is how we decide if it's going to be internal, external. I highly recommend to have your procurement and your vendor oversight department involved with that process if you do decide to explore outside. And I've done a number of conferences where we've talked about how to choose a vendor. I think that that is still applies here for AI, just the same as any other vendor. You might have different questions, right? So, developing a good scoring sheet that you can take out some of that bias and blind score organizations that you're looking at, deciding who to move forward with. But there should be a core set of people that look at your portfolio and decide what makes sense um, to manage govern that. Now, for an organization that's just saying we are new, we haven't done AI, what do we want to do? What do we want to build? First thing I say, and I'll scream this really loud, is don't take from your quality budget. This is not exploratory. So please don't take from your stars, your HEDIS, your like that's you need to set aside somehow, find the resources. Um, but I highly recommend starting with something that does have a proven ROI if you don't have much to start with, right? And I've seen great reviews from the member services call center side. Um, Friends at Kern Healthcare, they were at Rise Member Engagement Conference, and they said that they actually have scores higher for member engagement, um, customer, client, whatever you want to call it, satisfaction scores that they're using to score using AI than what they did for humans. And so I think they still have a mix of how they're doing it, but it's fabulous. You have AI can do, many different languages. And for our plans that have a diverse population, that's an awesome value add to be able to have AI that can talk in 50, 60 languages. I've seen it as high as 80. I think there's one that does 80. Um, so looking at something that has an ROI, you can, I don't want to say, don't look at you're going to take the place of, we can decrease our FTEs. You should look at this as you're going to augment what you're doing, you're going to improve your outcomes. And then, you still need teams that are there to help drive this. They need to understand the operations behind it. It can't be just tech folks. Unfortunately, you need some business people from whatever you're doing. So in this case, if you're doing call center, you need some people that understand that operation from your team perspective. But start small and decide what makes sense. One of the basic things that I've said to you, Nitu, when you asked me, well, what are some of the things that you're doing? Nobody should take meeting minutes, right? Nobody should be writing down meeting minutes anymore unless you're working with, like I work with some plans that don't allow, AI agents to take, like, Otter or any of those Copilot. That makes sense. I get it because you want to have that data security. But if you are a plan, you should be able to get some type of subscription or use, Microsoft Copilot to take meeting minutes. That's a huge savings right there. So when you look at some of the basic things, activities that we can just do differently, there's some core wins that you can get right off the bat and say, okay, let's practice this. Let's put this through our AI governance process. Let's see what it looks like and build that out. And then you can go on to bigger projects.
Love it. Love it. Thank you. Thank you. Dr. Majum there. Same.
Yeah. I love it. Don't take from the quality budget, Tina. uh,
No,
you know,
please.
this actually holds true for both health plans as well as organizations, whether you're a hospital system, any line of business for a health plan, as well as any type of provider organization. Um, when you haven't done anything with AI or you're trying to figure it out, of course, you have the governance. You want to make sure you have a governance council that's in place, but you will be bombarded by a multitude of options that are out there to make your life easier. But I want you to remember, what problem does your organization actually have that needs to be solved? Find that problem first that really needs to be solved, and then go about trying to find solutions that can solve it. From there, it's really important. Does your vendor have, how are they monitoring regulatory and compliance changes? Who's going to manage that? How is security in place? That is something that's going to be really important. That's there. Who carries the HIPAA contract that's there? And if you're in a large organization, you're going to have a full team that'll be able to tell you these things. But they're very, very basic questions that you can figure out before you get to the next line of business that's there. And you want to have a champion that's from your organization that's actually part of the process to see if this is a process that they would actually use within their system. And many vendors will have multiple programs potentially to help you. It can be very worthwhile to find a company that has uh, smaller solutions that you can choose from instead of a whole suite. So let's say you just want to work on outsourcing, uh, having, I hate using a chat bot or someone to help with your calls, or maybe you want to do quality. Find a program that's only that will allow you to start small and test with a single item. You don't want to buy a big suite, because if you buy a full suite of products that are there, it might not even work for you. So those are some of the key things that I recommend. And you want a partner, really. You want
Yeah.
a partner, not a vendor solution, someone that has the same philosophy as your organization and that's willing to move with you at your pace.
Yeah. Yeah. Great, great, great. I have one last question, and also to the webinar audience members, please type in your questions anytime. We did leave a bunch of time at the end here to make sure that we get to all of your questions as well. So, um, last question for both of you. Um, Next 3 to 5 years in health plan AI. So like imagine it's 3 to 5 years and imagine the pace of growth is just like improving. Based on what you're seeing today, what AI capabilities will be standard for health plans in 3 to 5 years? And where should plans be investing to make sure they're competitive? I'll start with you,
Yeah.
Dr. Majender.
Okay. Uh, I think the biggest area will be twofold. One is fraud, waste, and abuse,
Mm-hmm.
that they will be able to see patterns because they can look at large volumes of information in place that will help them. And I think the second area where you will see use is related to larger plans that have that data in place. They will be able to utilize that information and predict which members are the ones that need to provide more insight and guidance to now versus low touch and high touch. I think those two things will be most all health plans will be having that some sort of capability.
Yeah. Okay. That sounds great. Thank you. Um, Tina, what do you think?
So I think a couple things. I agree with fraud, waste, and abuse. You know, when I worked in state Medicaid, one of the largest fraud cases that I found was actually something that you wouldn't have guessed. Like it would have never triggered. But I kept seeing these authorizations for breast pumps. And I thought, well, that's weird. How many breastfeeding mothers are there that are ordering it from Medicaid? It's like every mother was ordering them. We found out that there was a company just finding out who was being discharged and sending them all and billing. So it ended up being a national situation. But imagine what AI can find, right? If that was a human seeing an error, not an error, but a pattern, I think AI is going to be just hugely advancing that side of it. And I know there's platforms out there developing this and looking at it. And I think especially on the Medicaid side that can be significant because every dollar counts, right? It starts to add up very quickly. But I do see that there's going to be, from my perspective, not only I think there's going to be advances in like care management, appeals, grievances, things like that. We're already seeing, some of those challenges like letter writing for appeals. Some of those core things are being done now by AI. Still, we need human input, the MD input, all of those types of pieces there. But I do think that that's going to be advancing. I do think what we see for quality is going to look very different. If I look back to what we were talking about earlier, a year ago, I would have never guessed that we were going to see what we're seeing now. So I can imagine 3 years from now, as I said earlier, I think STARS is going to be automatic. We're going to figure out how to make this data all like as real time as we can get it. But at the same time, we're seeing claims advance. We're seeing, uh, all of that process in itself. There's technology now that I just heard Epic launch their new Microsoft Copilot piece that's in the background where they will do the prior authorizations for the medications and everything before you even see the patient, right? So that's on the payer side. So if we have those level advances, that's going to push what we can do on the payer side even faster.
Yeah.
So if we can harness that information and that data, and even if it's not exactly been filled yet, right? I think we can see those triggers with PBM data and so on. We're going to have everything in front of us at all times. The only missing piece is making the member actually do an activity.
Yeah.
So I think what we're looking at is going to be very different than what we're seeing today and what strategy is out there. We should be looking at our strategies now. And I say that a lot. We shouldn't be, as you're looking at getting charts this year, NLP, all of these activities should be like second nature and you should be building it out now. You're going to need all of this in the next few years. Um, you mentioned the fraud, waste, and abuse part of it. I also think that um, how we interact with people from the hospital to home, I
Mhm.
I I personally hope is going to be different. I think we have opportunities to better have home care, and that impacts both the payer and the provider. We need people to be able to start to age in home and get care in the home. And there's so much technology with remote monitoring and all of that. And hopefully we could like encompass the member. It's always my dream to say, if we could use all of these things that we have to actually take care of the member and not have these dividers of, well, that's the lab, oh, that's the specialist. How do we circle around? I mean, it's an old thought that we've always had, but really doing it, it can be done with technology. But we have to all be able to have that data somehow, right? And have it in front of us. And I think it's going to happen in the might be 5 years, but 3 to 5 years, I do think it's going to be there.
Yeah. No, thank you very much. Both of you had really insightful thoughts here, and absolutely like the star super agent that just watches your star environment all the time. Like that is definitely near and dear to my heart. And I'm glad you brought it up. But like beyond the star agent, like, you have a super agent that's watching fraud, waste, and abuse. You have a super agent per member. You can deploy one per member for making sure that they can age at home and monitor all of the devices and remote monitoring things that they're connected to. Really, really appreciate your time. Really, really appreciate your insights. Thank you very much for the conversation. And everybody in the attendee list, like if you have questions later, please feel free to send them. And please fill out the surveys as you're heading out of here. And I hope everybody has a really, really great week. Thank you very much.
Thank
Thank
you.
you.